A 67-year-old man comes to the office due to 2 days of back pain. The patient was moving boxes in his garage when the pain started. It is not relieved by lying down and increases in intensity when he strains or coughs. The patient cannot sleep due to pain and has taken acetaminophen several times without relief. He has never before had such pain. Physical examination shows 2+ symmetric knee and ankle jerk reflexes. Straight leg raising test is negative. There is point tenderness to palpation and percussion along the midline at the 4th lumbar vertebra. Which of the following is the most likely underlying etiology of this patient's current condition?
Sounds like a lumbar herniation, but I mean, it doesn't have to always be positive. This is pretty self-explanatory that it's fine. I doubt it's arthritis. Like maybe. Damn it. Vertebral compression. Oh, wow.
Acute vertebral compression fracture can be caused by twisting, lifting, or other minimal trauma and presents with back pain and vertebral point tenderness. It typically occurs in patients with osteoporosis or other conditions associated with decreased bone mineral density.
Yeah, I was gonna. Oh, so it's just back pain that's just always there? Interesting. Okay, so the differential is just like constant pain. Dang, loss of height. Good start, guys.
A 38-year-old woman comes to the office due to a dry cough and malaise for the past 2 months. She has no prior medical issues and takes no medications. The patient reports no allergies and does not smoke. Vital signs are normal. Examination shows no abnormalities. Her chest X-ray is shown below.
This is sarcoidosis? Oh, she's 38, that's why. I was gonna say COPD, maybe even alpha-1 antitrypsin. But this is sarcoidosis, what?
This patient's symptoms of dry cough and malaise for 2 months with findings of bilateral hilar adenopathy on chest X-ray strongly suggests sarcoidosis. Sarcoidosis is a chronic multi-system disorder due to non-caseating granulomatous inflammation. It typically occurs in young adults, is 3-4 times more common in African Americans, and affects more women than men. Sarcoidosis is frequently detected incidentally on chest X-ray, and bilateral hilar adenopathy is the first manifestation of disease in 50% of patients. It can also present with symptoms of cough, dyspnea, fever, fatigue, and weight loss.
COPD.
Definitive diagnosis requires
flat.
consistent radiographic and clinical findings, and a biopsy demonstrating non-caseating granulomas. Bronchoscopy with transbronchial biopsy is often performed to obtain tissue diagnosis. If there is evidence of systemic involvement, more accessible sites such as peripheral lymph nodes or cutaneous lesions can be biopsied. Patients with incidental bilateral hilar adenopathy are typically monitored without biopsy unless symptoms develop. 1, 2. A 10-year-old boy is brought to an urgent care center by his parents due to a rash. The patient awoke yesterday with a rash on his trunk, but his mother says that it now seems particularly red in his underarms and private area over the last 2 days. He has also had headache, fever, and sore throat. He has no allergies, and his immunizations are up to date. Temperature is 38.3 C, 101 F. Blood pressure is 112/70 mmHg. Pulse is 108/min and respirations are 20/min. The patient is tired appearing but playful and in no acute distress. Examination reveals a fine erythematous, papular rash with a rough texture on the anterior trunk. The rash appears more concentrated in the axilla and groin and blanches with pressure. Tender, shoddy, anterior cervical lymphadenopathy is present, and the posterior oropharynx is erythematous with tonsillar exudates and soft palatal petechiae. The father adds, 2 kids in his class had the same symptoms, and now have peeling of their hands and feet. What is the most likely diagnosis?
Get fucked. Me. Oh. Fuck. It's like impetigo. The rash on his hands, sandpaper texture, ew. Desquamation. What? Okay. Man, I am stupid right now. I just know smart. Me small brain right now. I don't understand how that's supposed to. Okay. Feels bad.
A 22-year-old man in the intensive care unit is being evaluated for nutritional needs. 3 days ago, the patient was brought to the hospital after a severe motorcycle collision, in which he sustained traumatic brain injury as well as splenic rupture, with associated vascular injury. The patient required multiple abdominal operations and finally underwent delayed fascial closure this morning. Temperature is 37.1 C, 98.8 F. Blood pressure is 128/84 mmHg, and pulse is 90/min. The patient is intubated and receiving mechanical ventilation. The abdomen is mildly distended but soft. The dressing over the incision is clean and dry. Bowel sounds are decreased. Which of the following is the best next step for management of this patient's nutrition?
Hmm. 50% dextrose is kind of crazy. I would say TPN. I don't see a problem with that. Central. Bro. What? We're getting mollywopped out here again, bro. Get your ass whooped.
Enteral nutrition, when feasible, is the optimal form of nutrition for critically ill patients and has multiple clinical benefits: reduction in infections, maintenance of gut integrity when initiated early, i.e. 48 hours.
Yeah, but he had multiple abdominal operations and is now presenting with mild distension.
Due to a hypercatabolic state, critically ill patients, i.e. patients in the intensive care unit ICU, have increased energy expenditure and protein requirements. In such patients, early nutritional support can prevent malnourishment and improve overall outcomes. When initiated early, i.e. 48 hours, enteral nutrition ENIE via the intestinal route has multiple clinical benefits for critically ill patients, including a reduction in infections, pneumonia, and a possible reduction in mortality. EN may also help maintain gut integrity, preventing atrophy of gut and mucose-associated lymphoid tissue. EN formulas can be tailored to provide various amounts of carbohydrates, both simple and complex, protein, fatty acids, vitamins, minerals, and electrolytes. EN is typically delivered via a naso or gastric feeding tube. In patients with a high risk of aspiration, the tube is advanced to the postpyloric duodenum. Tube feeds can be initiated at a low rate, i.e. trickle feeding, and progressively increased. As tolerated by the patient, normal bowel sounds and/or evidence of bowel function, egg, passing flatus or stool, are not required for initiation of EN because they are indicative only of contractility rather than mucosal integrity and absorptive capacity.
I've gotten one right and I got it totally by accident. Feels bad.
1, 2.
It's because I'm tired. Oh well.
A 6-year-old boy is brought
This
to
is the
office
same
by his
day.
mother
I
due to
did
bleeding gums for
the
past 3
earlier
months.
few
The patient
questions.
brushes his teeth.
I did the earlier few questions and now I'm just tired. Even though it was only 6, I also did Anki and then, you know.
A 6-year-old boy is brought to the office by his mother due to bleeding gums for the past 3 months. The patient brushes his teeth regularly and visits a dentist twice per year. His most recent dentist appointment 6 months ago was normal. The patient has become easily fatigued over the last 3-4 weeks and is not as active as he was previously. Height is below the 5th percentile and weight is at the 25th percentile for age. Several small patches of hypopigmentation are noted on the trunk. The thumbs appear hypoplastic and thenar eminences are flattened. Laboratory results are as follows.
Okay, so he has maybe like tuberous sclerosis, maybe. Oh, wait. The thumbs appear hypoplastic. Oh, okay, so this is like Fanconi's anemia. Fanconi's anemia is not a benzene exposure, not that. Maybe. Probably. No. Fuck. What gave it away was the thumbs, but like, what is Fanconi's anemia?
This patient most likely has Fanconi anemia, FA,
Fanconi.
the most common congenital cause of aplastic anemia, i.e. bone marrow failure, pancytopenia. FA is typically an autosomal recessive disorder caused by a DNA repair defect. Damaged, unstable DNA impairs normal hematopoietic stem cell production and can also lead to increased susceptibility to malignancy, egg leukemia.
You know, these questions don't feel necessarily bad. It's just I'm just missing them. Like there are certain questions that I'm like, oh shit, I just don't know, man. Those are the ones that like make you just like you're between two questions. These ones are like, here we go, over there. I'm just getting them wrong, so they don't feel necessarily bad. I feel bad that I get them wrong, but I'm mentioning that because like, oh my god, if you started off like your boards with just like 5 questions like that, you may just fail that exam. Like if you don't get a freebie in the first 5, at like, oh my god, you're just gonna like lose it. Like if you flag the first 5 questions on your board exam, oh my god. I'm flagging them because there was something important in there that like either I missed it and I like just don't know enough on the subject, or because I can always go back and do flagged questions to like review, and just kind of look over flag. They help me like review them later, but also on the ones I do get right, but I'm like, oh, okay, well, let me make a card, Anki card on that, like sarcoidosis, bilateral hollout. You know, I can make it an image occlusion, something like that.
A 29-year-old woman, gravida 1 para 0, at 30 weeks gestation comes to the office for a routine prenatal visit. For the past week, the patient has had increasing pruritus that has been most severe on her palms. She has tried using oatmeal baths and lotion, but the pruritus has continued. The patient also has nausea and difficulty sleeping due to pruritus and increasing back pain. She now
I'm just gonna like, oh wait, let me check these. These look tough. Well, alk phos, that's fine. That's mildly elevated. Yeah, we're just gonna do that. It's intrahepatic cholestasis of pregnancy. I know. Ooh, fungi. Who the hell Who the hell's gonna do a woods lamp? Okay. We don't need to spend too much time on that one. Come on, guys. See, you need a freebie. You need a freebie like this one. This one's also pretty much a freebie in my opinion. But I can see why anybody else could not because they don't know.
A 3-year-old boy is brought to the emergency department by his mother due to cough and difficulty breathing. The patient was playing outside with his older sisters when he started coughing uncontrollably. He has been coughing with audible wheezing for the past 30 minutes. The patient has no chronic medical conditions, but has had rhinorrhea for the past few days. Temperature is 36.7 C, 98.1 F. Blood pressure is 92/48 mmHg. Pulse is 114/min, and respirations are 48/min. Pulse oximetry is 91% on. Room air. The right lung has diminished breath sounds and expiratory wheezing. The left lung is clear. Supplemental oxygen is applied. Chest X-ray reveals hyperinflation of the right lung and left mediastinal shift. Which of the following is the best next step in management of this patient? Sudden onset respiratory distress with unilateral hyperinflation and mediastinal shift on X-ray are concerning for foreign body aspiration. Rigid bronchoscopy can identify and remove the aspirated object.
Okay, so I was thinking it was like a tension pneumothorax, like something like that, but that would be deflation and mediastinal shift. So that was stupid of me, I think. Yeah, see, literally metal, yeah, what I said, yeah, would collapse. See, I knew the answer, but I didn't know what hyperinflation meant, and I guess hyperinflation means obstruction. Foreign body aspiration, same thing. Okay, interesting. We learned something.
1, 2.
I don't like that.
A 4-month-old boy is brought to the office due to abnormal twisting movements of the limbs and torso. The patient also is not able to push up on his arms when prone. He was born at full term to a 30-year-old woman by forceps-assisted vaginal delivery. The delivery was complicated by cephalohematoma. The patient has not been evaluated since discharge at age 2 days. Vital signs are normal. Weight and length are at the 50th percentile for age. His eyes are crossed, and he does not react to sound. Dystonic. Extremities are noted on examination. Which of the following is the most likely explanation for this patient's current condition?
Well, physiological, bro. This kid is like messed up, bro. MECP2. What is that? Fuck, I should know that one. Fragile X? No, I thought Fragile X was like an FMR1 repeat. Although, I just want it. I just want to click it. I don't know what is on chromosome 4, to be honest. Bro. What? Oh my god, dude, this explanation's huge, too.
This infant who was not evaluated
bro,
beyond the
there's no way I
immediate
could have
newborn
diagnosed
period
this
now
one.
has dystonic movements, i.e. involuntary twisting writhing. A finding concerning for bilirubin-induced neurologic dysfunction bind. Bind occurs when bilirubin concentration dramatically rises. Total bilirubin 30 mg/dL and exceeds the binding capacity of albumin. Unbound bilirubin crosses the blood-brain barrier and deposits in the basal ganglia and brainstem nuclei, oculomotor auditory, causing neuronal damage.
Holy shit.
Comma, acute bind typically presents with lethargy, tone abnormalities, and high-pitched, inconsolable crying. However, symptoms may be subtle or overlooked. Although many patients have no known risk factors, the cephalohematoma this patient sustained during delivery likely led to localized red blood cell breakdown that caused unconjugated hyperbilirubinemia.
So we just don't do forceps delivery anymore.
Comma, prolonged unrecognized or untreated hyperbilirubinemia can lead to chronic bind eye kernicterus, typically presenting after early infancy with irreversible neurologic damage. Common manifestations include hyperkinetic movements, egg, chorioathetosis dystonia, sensory neural hearing loss, and abnormal eye movements, egg, upward gaze palsy. Developmental delay, egg, inability to push up when prone at age 4 months is also typical. Serial examinations and/or bilirubin monitoring in the early neonatal period, particularly in patients with risk factors, as well as early treatment of hyperbilirubinemia, egg phototherapy can help prevent bind.
wonder if this is permanent.
Bilirubin-induced neurologic dysfunction is due to extreme unconjugated bilirubinemia, which unbound bilirubin crosses the blood-brain barrier. Chronic disease, i.e. kernicterus, results in hyperkinetic movements, chorea, dystonia, sensory neural hearing loss, and gaze abnormalities.
Interesting.
A 78-year-old man is brought to the emergency department after a brief episode of syncope. Since yesterday, he has been fatigued and lightheaded. The patient has no chest pain or palpitations. He has a history of hypertension, stable coronary artery disease, type 2 diabetes mellitus, and hyperlipidemia. Blood pressure is 82/44 mmHg. The patient appears lethargic and mildly confused. The lungs are clear to auscultation. The extremities are cold and capillary refill is 3 seconds. ECG is shown in the exhibit. Which of the following is the most appropriate next step in management of this patient?
I had a patient come in with like a heart rate of like 44 or something, right? I think it was just like, I was like, that's like really low. And she had just had like, I don't know, some sort of bariatric surgery. Like she had just like skin, like she used to be like so fat or something because her skin was just like, you know, like melting like chocolate kind of all over her body. And her heart rate was so low, and I was like, that's weird. The doc allowed me to do an EKG. The EKG literally looked like this girl was about to bottom or die. Her blood pressure was fine, which was good. But bro, I still have that EKG because that EKG was the wildest shit I ever seen. Like, it just looked messed up. But I just kind of chalked it up to just, you know, her body just readapting to losing all that fat, and like, you know, don't make a big deal, especially because here's the thing that I also, why I didn't like push it, mostly my biggest reason, which is what, you know, primary care has taught me, which is if somebody's asymptomatic, if they're not having any complaints about it or anything, you don't usually have to pursue it. Now, something like a diastolic murmur, you know, that kind of BS, hypertension, you gotta like push it, right? We know what happens with those. But if you're just unsure and the patient is asymptomatic, you know, you don't have to go crazy.
A 2-day-old boy is being evaluated in the nursery. The patient was born at 39 weeks gestation via spontaneous vaginal delivery to a 17-year-old prima gravida. The pregnancy was complicated by lack of prenatal care. The delivery was uncomplicated, and the patient had APGAR scores of 9 and 9 at 1 and 5 minutes, respectively. He is formula feeding well and has stooled twice but has had only a single wet diaper in the first 48 hours. Weight is 2.89 kilograms, 6 lb 6 Oz, down 3% from birth weight. Physical examination is unremarkable. Which of the following is the best next step in the evaluation of this patient?
Single wet diaper. So they're trying to say that like he has only peed. So maybe, well, okay, so I'm not gonna do, let's see, how would, well, there's no suggestion to suggest, there's nothing to suggest that they're that. Fuck that. I don't know about that. But why? Probably. Yeah. What is this person? What they what? This patient has neonatal AKI. Damn, they coming out with AKIs now? Coming out the fucking womb?
Normal urine output in a neonate is defined as 1 void per day of life. This infant has had only a single wet diaper in the first 48 hours of life, and therefore has oliguria from neonatal acute kidney injury (AKI). All neonates with oliguria require further evaluation with the following: renal and bladder ultrasound (RBUS),